Welcome to the Global Health series. I'm Vivian Kopsinje-Birchall, your host, and with me is the amazing, talented Dr. Miriam Mutebi. She's, first of all, welcome to the series.
Thank you so much for having me.
And thank you for being here at the Global Health Catalyst. Maybe to kick it off, what do you do, where are you based, and how does your work intersect with the Global Health Catalyst?
Sure. Thanks for those questions, Vivian. My name is Miriam Mutebi, and I'm a breast surgical oncologist, which is a breast cancer surgeon based in Nairobi, Kenya, at the Aga Khan University in Nairobi. I wear many hats, and so currently I'm the chair of the African Organization for Research and Training in Cancer, which is really an organization that's been trying to transform cancer care and control in the region. And that has been one of the areas of intersect, especially for, and why we're quite keen to be a part of this Global Health Catalyst event, because what happens is, Vivian, that especially in many parts of sub-Saharan Africa, we do know that we are having an increasing incidence of cancers. We've noted that our incidence has almost doubled in the last 30 years, and that's due to a number of factors. But I think what's even more alarming is the number of deaths, and it's really around how do we shift narratives around that? How do we reframe or restructure our strategies to actually mitigate this emerging crisis?
This is a perfect theme. It perfectly aligns with this year's theme, the Cancer Moonshot 2.0, which is really trying to expand the goals of the moonshot to sub-Saharan Africa and to the rest of the world, actually. So how do you see your work in organizations working collaboratively with the Global Health?
I think it's important first of all, we applaud the initiative to expand the Moonshot initiative. It's very timely. What we are advocating as well is what we call a ground shot approach, or which really, simply put, is even as we're reaching for the stars, let's stay grounded. And what do I mean by staying grounded? The reality is that many patients in the world, especially in low and middle income countries, lack access to the basics of cancer care. And we do know that what does make a difference in terms of the overall outcomes are really the core pillars of treatment, which is basically chemotherapy or targeted therapies, radiotherapy services, surgeries, and surgical services. I'm going to go on a bit because I think one of the missing pieces, and we sometimes say surgery is a neglected stepchild of global health and global oncology, because what we do know, or what many people may not realize, is that 9 out of 10 people, Vivian, have no access to safe, timely surgery. Now, if we think about that in the context of cancer care, what's not intuitive to many people is that surgery is one of the major pillars of cancer control, and it really goes across the entire spectrum, whether it can be preventative. For instance, you have a polyp and we remove that so it doesn't turn into a cancer. You have, it can be diagnostic, we take a biopsy. It can be curative, where you have maybe a tumor and we resect it completely. It can be palliative or supportive, where we sometimes, if you're having like a large tumor that's causing or improving your quality of life, or impeding your quality of life, sometimes we actually remove it. It's not that we might not necessarily, change the overall outcome of the disease, but we can definitely give you quality of life. And it can be reconstructive. For instance, you've had a limb salvage and we're reconstructing or giving you a new breast. And so surgery really goes across the entire continuum. But I think many people don't realize that more than 80% of all cancer patients are going to require surgical services. And more than a third are going to need repeated procedures. So even as we talk about access to, treatment services, by access to treatment, sometimes we think about we've installed a radiation machine, we've perhaps installed new chemotherapy. It really comes down to the workforce, and I think that's one of the overall resonating themes, is how do we build the workforce? Because even when we give, say, for instance, chemotherapies or radiotherapies, what sometimes is a definitive treatment in terms of removing the tumors as a surgery. So if you don't have good surgeons, it doesn't matter how excellent your chemotherapy is, how excellent the radiotherapy is, if we're not able to remove it completely or remove it in a safe, effective way that's not going to increase your complication rates, then that's really a disservice to a patient. So really saying that it's important to have the entire spectrum of care.
Right. And so you've mentioned so many, or glossed over so many areas of disparity that where intervention needs to happen. So in terms, if you had this huge vision about the possibilities of collaboration through the Global Health Catalyst, where would you want to see the emphasis?
I think there's several areas of potential shared learning because again, it's really about directional and what can we learn from high-income countries, what can we learn from low-income countries, what is the best practices, what are the innovations and strategies that we can sort of think about. I think one of the key areas is really thinking through providing access and looking at innovations that help to maybe bridge some of these gaps, in recognition that innovations of technologies are not necessarily a substitute for dysfunctional systems, but how do we get these new interventions? There's lots of, throughout the course of the sessions, we've had quite a number of innovations, whether it's around telehealth, but really looking at how do we integrate these into systems and how do we help these, how do we strengthen systems to give better care delivery. It also comes in around areas of education and opportunities for shared knowledge and decision making. I think we've heard over the course of the day that setting up global universities and I think the pandemic has actually showed us that we're more, connected than we think, which is great because, 5 years ago we wouldn't think about, tuning into Zoom, and right now it's become a way of life. And so taking this to the next level in terms of, planning treatments, having a global community really that's at the heart of where I see the catalyst and sort of working with our other organizations like Aortic to really try and come together and make a difference for patients. One of the other areas of, I think, key areas of potential collaboration is really around research as well, because there's a paucity of data. I mean, we've had a recent Lancet Commission report of cancer in sub-Saharan Africa really describing the dearth of data. And we see for us, in order to inform policy, we do need the data. And so how do we how do we build up the infrastructure, the research infrastructure that helps to facilitate and translate into policy? And so I think there's low-hanging areas where we can sort of sit down and start to build systems where we're actively collecting our data, and not just actively collecting it. It's not just hanging there for data's sake. It's really about how do we interrogate that data and how do we use that data to inform our policies and practices in terms of our service provision for our cancer patients.
Absolutely. So you mentioned, and I've heard this theme over and over again about the need for research and capacity building and research. What are some of the specific needs when it comes to research? Because, just like you mentioned, you want data, there's the need for data, but how do we store data? What's the infrastructure like now in the healthcare systems, at least in East Africa or Sub-Saharan Africa? And what areas really need a boost?
So I think one of the challenges is actually the research culture that exists. And I would say there's a lot of heterogeneity that exists. First of all, in recognition that Africa is not a country, so there's lots of variations across different centers. However, we did a recent bibliometric analysis, Vivian, where we sort of looked back over the last 12 years and sort of said, how much research are we actually doing? And so, and looking at the whole body of research and then narrowing that down to, well, out of the entire research that's being done on the continent, how much of that is actually cancer research? And what we found was really, I think, an opportunity and a platform for us to do better, because what we found was that only 8%, 7.9 to be specific, of all research on the continent is related to cancer research. Of course, it is increasing. I would say definitely, if we look at the rate of increase, like 2013 was about 6.5, almost getting to around 9%. which is much faster than the growth anywhere else in the world, but it still shows that there's an opportunity for us to do better. And if we look at the body of the cancer research that was done, what we saw was that 5 countries from North Africa actually provided almost 64% of all the research. And countries in sub-Saharan Africa, all the countries in sub-Saharan Africa produce roughly about 14% of all the research. So it really begs the question, because if we're using this data to make decisions, how do we actually know what's the true state and what's going on? Now, when we think about research, it's not a quick sort of dive and do. There's lots of barriers. I like to say I'm a breast surgeon by day and cancer researcher by night. And so sort of talking to colleagues and looking at what are the challenges that hamper us getting research. We're all saying, yes, there's a need for research, but how do we, one, start to inculcate research early into our practice? For instance, what happens in most trainings in African countries is that you maybe encounter research by the time you're doing your medical training as a postgraduate, and maybe that's your first encounter with doing maybe a dissertation, and that's where you're getting introduced. And we're saying, how do we plant the seed earlier? How do we build even into our basic medical training? Many centers around the world will let you take a year off, or even in your undergraduate or your basic medical degree have opportunities for interacting. And so it's really about building that community. Even as you build that community, it's how do you provide the support that facilitates good research and data entry. What happens is, because of the paucity of the workforce in many parts of Africa, there's that incredible tension, because you're having, I would say, oncologists, more than 31% of oncologists are seeing more than 500 patients per year, which is really a high number for oncologists anywhere in the world. And it's how do you sort of get that tension between service delivery? You have these long queues of patients who need to be sorted. You're the only oncologist around for maybe a couple of miles. And then how do you still get time between all that to do good research? And good research does take dedicated funds, dedicated teams to actually support. It's not just collecting the data, it's managing the project, writing the grants. So all those facilities and all those skill sets need to be in place for us to do better research. And so part of the collaborations would be really looking at how do we work together, and how do we build together co-develop systems that work for Africa to actually help improve the research output. And that's really one of the key tenets for the African Organization for Research and Training.
Right. No, thank you so much for that, great overview of the challenges with research. And one of the things that probably won't get much deeper into it, but it's the whole, the matrix for measuring things, especially in Africa, because when we're talking about disease in general, or healthcare in general, there is this whole, it's like a salad of everything that people can't differentiate whether it's cancer or spiritual or this. So it's harder to extract the data because of the cultural influence, the faith influence. Maybe just very briefly, and we can get into it some other time, but
Sure.
What has been your experience, especially dealing with cancer, with communities that are, their lifestyle is really a blend of culture, faith, and healthcare?
I think that's not unique to Africa, but what we do see certainly around many communities is the intersect. If we look at patients in sub-Saharan Africa, we see that many of the patients are diagnosed with advanced disease and frequently do not complete their care. And this, Vivian, tends to be an intersection of a number of factors. One of the factors is the fact that patients have to pay out of pocket in order for them to access care, frequently resulting in financial toxicity and catastrophic health expenditure. The second is the systems themselves sometimes are not responsive or reflective enough, where we know, for instance, that patients will see 4 to 6 healthcare providers before a definitive diagnosis of their cancer is made. But then sort of drilling down to the question you're asking about the social cultural barriers, again, these are very, I would say, depending on the community, can be very pervasive and actually determine what the outcomes are. And sometimes I say, telling a woman in sub-Saharan Africa that you have a breast cancer, for instance, is not just you have a breast cancer. It's you have a cancer. You could lose your, you could lose your livelihood because people sometimes get, discriminated on, just discriminated because they have a cancer diagnosis. You could lose your family because sometimes you go home and you say, honey, I have a cancer, and you're told, honey, there's a door, don't let it hit you on the way out.
Yep.
There are many, partners who are supportive, and don't get me wrong, but it's still, pervasive enough to be a problem. And in our research, because as I said, my other hat is a cancer researcher, doing a deeper dive into the barriers behind this, we saw there's still a lot of stigma that exists around a cancer diagnosis. So, and sort of going in, of course, some of our pre-biases that we acknowledged as researchers was that perhaps this was something to do with the level of education. And so we did studies across East Africa where we looked at both high income and lower socioeconomic status, and our results were actually surprising because it didn't matter about the level of education or the socioeconomic status. The stigma actually sort of trumped everything else, and so patients, irrespective of their level of training, of their partners, or their socioeconomic, would still get thrown out of their homes and lose their sources of livelihood. And so that's one of the aspects of the social cultural barriers. Again, you've touched again on the use of alternative therapies and faith. As I said, that's not unique necessarily to sub-Saharan Africa, and we see different variations of that across different continents, but it's also enough of a hindrance to accessing care. One of the other things we always sort of discuss as clinicians is that sometimes when you have and patients come to see us on a routine basis and say, when you have a cancer diagnosis, at least in Africa, everybody becomes an expert, right? So patients will come in and tell me, Vivian, so what do I eat? I've been told don't take sugar, don't take proteins, don't take carbohydrates, don't take, you can only take vegetables, or you can't even take plain water, it needs to be alkalinized. So there's lots of things on social media and lots of things out there. And so it's really about how do you provide a platform that's providing safe, timely information and important information that really helps to, I would say, tackle some of these barriers. And then one of the critical things that's close to my heart is really around collectivism. And I would say in Africa, as I think I mentioned earlier, our strength is our community. But sometimes that's a double-edged sword, because what happens is, Vivian, you find that sometimes the patient loses agency. We've talked about, of course, Ubuntu and really having that community spirit. But then when the patient loses their own voice in that, it starts to become a problem. I'll give you an example as a breast surgeon. I frequently have patients who come in with early disease. And they sometimes, if it's a single isolated site, we have the option of either doing a breast conservation, meaning we remove just the lump, or we can do a mastectomy. And you sort of give both options to the patient and ask them to go home and think about them and come back. And then sometimes you'll come back with an entire clan, and there's the clan elder, and he's like, we have decided, and we're like, who's we? Who's we?
Oh my goodness,
Who's
that
we?
is so true. Yeah.
And you're like,
so sad and true.
And so it's like, we have decided she will have a mastectomy, and you're saying, but what does the patient want? And the patient's like, well, I would really like to keep my breast. But you see that this is the crux, Vivian. Unless we empower our patients, because she wants to keep her breast, but she's saying at the end of the day, they're the ones who are paying for it. So they're the decision makers. So how do we empower our patients, male or female, to have agency? And that can only come through health financing. We've really talked about thinking about structures around universal health coverage, access to care. We do need to think creatively, because some of our countries do have a national hospital insurance fund, but it's not infinite. Yeah. We do need to think about what are the creative ways of financing that we can start to build that would actually ensure that our patients are able to continue or at least complete their treatment journeys. So those are some of the issues that I think, well, I shouldn't say issues, some of the opportunities we have to intervene and make a difference.
No, that's great because you touched into something that I would have had as a follow up. What like, I wanted to ask, like, what are the specific areas, given that you've outlined the different cultural and spiritual components of care. Like, how would you advise the Global Health Catalyst to support, to intervene in that particular area? And I mean, it's something that we could talk about some other time, but I'm just curious because we're trying to catalyze collaborations to address some of these disparities, and they are real. And when you talk about sub-Saharan Africa, and they're a huge part of healthcare. So, and just kind of thinking aloud and try, what can we do as a catalyst to in that specific area?
I think somebody made a comment at the one of the sessions at the conference is that in order to help me, you need to understand me. And I think with understanding is the first step. Having the humility to sort of sit down and think about, we're not necessarily going to be prescriptive. Let's see where this particular patient is coming from. And that really sort of, circles back to research, right? Because we need to understand what's going on in the community, because we can put up, the greatest infrastructure, the greatest workforce, but if patients are going to come in and, not complete their care because of one or two factors, we really need to understand what's going on in the community. And so part of the strengths, and where I see the Global Health Catalyst helping as well, is really around facilitating community or participatory research, and really getting that African spirit into, yes, we have a problem. How do we, around the cancers, but then how do we increase awareness, which really goes a long way towards, earlier detection of tumors. How do we find out what those the nuances, because again, as we said, Africa is not a country. The social cultural barriers in West Africa, or even within the same country, same region, are going to be totally different.
Same country.
How do we customize each of those, and then, but still have that global presence, almost like sort of think global but act local. Precisely. And so I think that's going to be one of the first steps that we have, and then looking more at the implementation science, looking at a broader sort of systems perspective, and looking at what are the gaps that we're identifying, what are the strategies, and we've talked about innovations, and really looking at, do these innovations work? If they don't, it's definitely an iterative process, but I'm sure, working in collaboration, and that's one of the key things that's resonated, it's definitely going to be an iterative process. From the other half, a couple of things and publications about things that did not work, but I think that's also important in terms of learning the system and sort of, failing, but as Samuel Beckett says, failing but failing better, and how do we build back, so that's I think one of the key areas that I see the collaborations with the Global Health Catalyst working.
Dr. Miriam, I just feel like I could use days and days of just interviewing you and still not exhaust what we have to talk about. This is a great foundation. I am so grateful that you made the time to speak with me.
No, always happy to. Always happy to. We're happy to come back. And
Absolutely. And like you said, we have Zoom, so I hope that if I don't have to wait until the next Global Health Catalyst session.
No, and we're taking the opportunity to invite you to the African Organization for Research and Training in Cancer conference that's happening in November in Dakar. And so
Senegal.
It's an opportunity, exactly. It's an opportunity to come through. It's really the biggest convention for anyone who's involved in cancer care in Africa, all parts, and it happens every 2 years. So it's really a good conference to, one, enhance and amplify the Global Health Catalyst initiative. So I'm hoping that we'll submit a few abstracts and get more opportunities for collaboration there.
Absolutely. No, thank you so much for the invitation. I hope the Global Health Catalyst team is listening. And
I hope so too.
But no, again, thank you for all the work that you do for motherland, for humanity across the world, and thank you for being here today.
Thank you for having me.
And to our viewers, thank you for watching. Look out for more videos about what's happening in global health. But for now, thanks for watching. Till next time.